Hello and welcome to the Leicester Royal Infirmary. My name is Harman and I am one of the emergency department registrars here. In this video, I am going to talk about delirium assessment and its early recognition in the patients aged 65 years and older. Delirium is an acute disorder of attention, awareness and cognition, relatively common in patients of age 65 years and above. But the clinical diagnosis of delirium is often missed. This leads to poor outcomes such as increased morbidity, mortality, distress to the patients and carers, and the length of stay. Royal College of Emergency Medicine national report published in 2019 and 2020 concluded that only 16% of the eligible patients had a documented assessment of cognitive impairment in the emergency department. This indicates that awareness and reporting procedures need to be improved. If we look at the prevalence, only 1 to 2% of the overall older population in the community suffers from delirium, but it rises to 14% among individuals who are older than 85 years of age. In hospitals, delirium affects up to 56% of the patients on the wards and increases to 70 to 87% in intensive care. There are 3 types of delirium: hyperactive, hypoactive, and mixed. In hyperactive delirium, which is probably the most easily recognized, patients may seem restless, agitated, and unusually vigilant. They may resist personal care or respond aggressively to it. Whereas in hypoactive delirium, patients are more lethargic and quieter. They may stop eating as much or become less mobile than usual. They may spend more time in bed. Patients with mixed delirium, they may show symptoms of both hyperactive as well as hypoactive delirium at times. Among older people, including those with dementia, hypoactive and mixed delirium are the more common. There are many screening tools which exist, but detection of delirium is frequently delayed or missed. Single question in delirium, which is also referred to as SQUID, is a very simple tool. It is used to screen the patients aged 65 years and older for delirium. To start screening, all you have to do is to ask, has this patient been more confused lately? To use SQUID, you must know what is normal for the patient. If the answer to SQUID is yes, then you should perform 4AT to confirm the diagnosis of delirium. 4AT is a diagnostic tool based on DSM-5 diagnostic criteria for delirium, which I have included in the next slide. 4AT has 4 parameters, which are alertness, AMT4, attention, and acute change or fluctuating course. The score ranges from 0 to 12. Score of 4 or more is suggestive of possible delirium. Score of 1 to 3 suggests possible cognitive impairment. Document the diagnosis of delirium clearly in the notes. Once the diagnosis of delirium is established, the most important action for management of delirium is identification and treatment of the underlying cause. At the same time, management should also be focused at non-pharmacological measures, the supportive care, and preventing the complications until recovery occurs. In summary, treat the reversible causes, review the medications, especially stop and avoid any medications with anticholinergic properties, normalize the behavior and routine, including the meals, activity, and the sleep habits, minimize the distress to the patients. Please do not do any unnecessary procedures or physical restraints. Pharmacological therapy should be reserved for the patients who are a threat to their own safety or the safety of others. In the end, the take-home message from this video is to start screening patients aged 65 years and above using single question in delirium followed by 4AT if the answer is yes to SQUID. It can contribute to delirium detection and the clinical care of the hospitalized patients. Has this patient been more confused lately? It is all you have to ask to save someone's life. Thank you for your time. Bye.